sometimes it's hard to find the common ground because there may not be a consensus amongst the group that maybe someone says, I think it should be drug Z, and over my dead body, I think it should be drug A. So the one thing I don't know for sure is if there's a general collective consensus about the direction of hypertension care in terms of being fairly prescriptive, because that's one thing that we did way upstream. So I think it's general the most important. I think a registry is the most important. But I think a second is an organized care plan, because without a clinical background, without a plan, it's hard to execute.
I mean, it's Lean 101. You got to standardize before you got to reduce the variation, and then look at improving.
Well, the question is, in the absence of firm evidence, should there be
I sent you the agenda,
choice?
and I keep building on the end.
Chaos,
So,
or
like,
should there be
so
order?
just if you want to just do
Direction.
a pure
So
agenda,
I'm very
I
control freak, but I think, well, if you don't know what to do, we should all do the same thing.
I'll be right back. It's loaded up there, but I keep adding to it. I know I have to keep stuff, but I want to run to
Some people are spending $1,000 a year.
I agree. Yeah, it's a perfect example, because that's an example of, is it the pills? I think people have this belief that it's the pills, but I think it really is the system. So I agree.
No. So I think that
It might be. It might have been separated at birth.
Which is another missing piece. I think this is the people, because they believe in their system, they translate it to the patient.
Yeah, and you can actually view, say, LDL, A1C, and blood pressure are actually, in my opinion, surrogate markers for inheritance. So you say we don't have an inheritance metric? I guess you do. Because a person on 3 drugs under control, I mean, you know that a vast majority of that resistance is going to be, like someone on a high-dose hypoxia with an LDL of 175, okay, you know that the average LDL reduction will be 52%, so that's probably an adherence issue. So people who say we need better adherence data, I say you have adherence data. You have adherence data in your surrogate markers.
It's true.
In general.
In general. I used to do that with my patients. I'd get their LDL and it's exactly where it started before the statin.
So increase it.
So we had to be careful.
Yeah.
What we would do is we would basically call the patient and say, I know you're taking your med. Could you be extra careful this time? Take it and we'll check it again in 2 weeks. But just be extra careful. But it's, of course they weren't taking it.
I know.
As opposed to increasing the dose. Because you knew. How could it just stay the exact same? I mean, there's no statin that does nothing.
Yeah. Doubling the dose of a drug which isn't taken does not do that. I agree. I mean, we have the same thing. It's just easier though just to change it to jump it to the next thing and just move on to the next patient. It's a lot easier. It doesn't necessarily work. Awesome. Okay. Well, feel free to steer me and interrupt me and all that kind of stuff.
Do we need to, okay. Okay, if you'll take your seats, we're about to get started. Well, thank you everyone for coming back after the break, and I know it's hard to break up the wonderful networking that's going on. Again, I'm Jerry Pence. I'm Chief Medical and Quality Officer for AMGA, and also the leader for the American Medical Group Foundation's Measure Up Pressure Down High Blood Pressure campaign. And many of you, in fact, almost all of you, are part of that campaign. So today and tomorrow we're going to be talking about high blood pressure and using the data to drive improvements. And as John mentioned, I think there is a unique opportunity for the Anceta collaboratives to lead the way for all the AMGA groups that are participating. And just FYI, we're up to 142 medical groups across the country that are participating, and that represents 42 million Americans. So we think we have a unique opportunity not only for the ANSETA groups to lead the way, but actually for AMGA groups to lead the country in this initiative. It is my pleasure now to introduce Dr. Mark Jaffe. I last heard Dr. Jaffe speak at the National Forum for Heart Disease and Stroke Prevention in Washington, D.C. He knocked the socks off of the audience, so I think you're in for a treat. Dr. Jaffe joined Kaiser in 1993 and practices endocrinology and internal medicine at Kaiser South San Francisco. He attended UC Berkeley, go Bears, and graduated with a degree in linguistics. And I just lost my slide here. He completed his residency at UC San Diego and endocrinology fellowship in research in diabetes at UC San Francisco. And he leads, and you'll find out more about the Kaiser Permanente Northern California phase cardiovascular risk reduction. And probably the most important thing is he's a Cal football and basketball fan. So anyway, please join me in joining and welcoming Dr. Mark Jaffe.
Great. Well, it's a pleasure to be here, Jerry. Thanks for inviting me, and it's great to see everyone here. I caught the tail end of the last conference with the Jerry Maguire video, so I'm afraid that if you were expecting something as entertaining as that, what can I say? I'm sorry. I'll just set. How about this year? I'll set the expectations low, and then I won't disappoint anybody. But it really is a thrill to be here, and what excites me is hypertension and looking at the data. And so, what I'd like to do today is tell you what we've done at Kaiser Permanente, Northern California, for the past 10 or 12 years or so. And I think my hope is that you'll look at this and you'll say, well, some of this is irrelevant, some of it might be relevant, this might or might not apply to my own care setting, this I like, this I don't like. But certainly I'm not here to tell you that I have the answer, or Kaiser Permanente Northern California has the answer. But we feel that these sorts of activities, which we've been tirelessly working on for the past decade or so, really are demonstrating impressive results and results for the members that we serve. And I know you all are here because you have a commitment to serve the groups of patients that you provide care for. So in that spirit, I'm really delighted to be able to share with you what we do in Northern California. Let's take a look here. And we'll just start with some. Let's see. I have a lot of devices up here. I bet you one of them moves the slide, right? Forward. How about this button here? Maybe next. I bet you next would do it, huh? There you go. So, here we go. We skipped something here. Okay. So financial disclosures, so that those of you that care, I think this is, it's not for CME, but I think it's important to know that Kaiser pays my salary and nobody else. And I don't work for a pharmacy-sponsored speaking bureau. I have some 401k, some blended mutual funds. I have my own laser. I didn't bring it, but I actually have my own laser pointer, and usually I'll pass it around to the crowd and make sure there's no drug. Someone can inspect it to make sure there's no drug name on it or something. But you actually can, just so you know, you can actually purchase a laser pointer without a logo on it, and I encourage you all to do it if you give any speeches. So I just think it's important because that's who pays my salary. So hypertension, I know everybody's here because hypertension it's a big problem. 65 million adults in the United States. This is from the NHANES data. We know what to do, right? I mean, we know how to treat hypertension. That's no mystery. Yet, despite that, more than half of all Americans have blood pressure which is under controlled or poorly controlled. And a larger number of people don't even know they have hypertension. So it's really, I think, kind of tragic in a way, in a societal way, that it's almost like someone who's bit by a snake, and we have the anti-venom, and we just can't get it to them. So I feel that's really, it's not an opportunity, really, it is an obligation. So I'm happy to share with you what we do. Just a little bit about Kaiser Permanente Northern California. We're a big group, if you call 3.3 million members big, almost 3 million adults, more than 7,000 docs, 17 medical centers, and 45 facilities. And I think one of these points, right, probably this thing right here. I work at, see this diamond? That's where I work, right there, South San Francisco, which is just a short hop here on the BART station. So I think today what I'd like to talk to you about the components of what break down what we do and why we think it works. And I think this is a large kind of checklist, and we'll talk about many of these things today, but not all of these things today. But When people have asked us for a while, for the past 4 or 5 years, what exactly is it that you do? And sometimes it's hard to know because it's all we know. It's just what we do. We go, I don't know, isn't this what everybody does? But people say, no, you need to describe what you do. And so this is the checklist. Unfortunately, just checking off all the boxes we found will not lead to success because they really need to be integrated and there needs to be a plan and a mission. But we have an extensive network of physician champions. A champion is someone, it may not be a cardiologist or a nephrologist or an expert. It usually is a primary care doc or a family practice doc, someone that knows how to get things done. And in my opinion, they're the real disease experts. And every time you have a talk led by a cardiologist or nephrologist, and I have many friends who are cardiologists and nephrologists, you start talking about things which I think move farther and farther away from the bread and butter of hypertension care, which is applying a very simple, affordable, effective set of medications, encouraging adherence, frequent monitoring and checking, and establishing a relation and do barrier busting and addressing people's fears and concerns. And I really don't think that you need a tenured faculty member of a medical subspecialty group at university to be able to deliver this. So I really encourage you to look for those experts amongst you who are really in the trenches, so to speak, who provide the care every day, and acknowledge them because they're really not only responsible for the care, but I believe they're responsible for the leadership. So we have a network of physician champions, and little by little, we've weeded out all the specialists, and it's a network of I think specialists in general primary care. And let's make no mistake, they are specialists, and they deserve to be acknowledged. We have simplified evidence-based guidelines. We'll talk a fair amount about this because Jerry and I were talking a couple of meetings ago about, well, what is the most important part? And of course, there's a lot of important parts, but I think that having a uniform evidence-based guideline is really important, as well as having registries of high-risk individuals. In other words, you got to know who it is we're talking about. You got to be able to draw some boundaries around something so that, am I treating everybody on the planet, everybody on this planet and other planets, just people in my zip code? I mean, we need to define what it is that we're doing so we can know if we're successful or not. We need to measure and we need to repeat and measure and measure and measure. We need tools and systems to help us. We need support locally because if my regional director says it's important, but my medical director at my medical center doesn't think it's important, then I'm in big trouble. It's like you need to have a chain of command which is unbroken, so you need local support as well. We need a network, which is much like you are doing here, but we have a network of champions where we have support, we share best practices, we share successes and failures. It's some hand-holding, some cheerleading, some innovation sharing, and all that other stuff that happens behind closed doors, and it really is about relationship building. We align the incentives because we don't want to, on the one hand, send a report out saying how well you are doing in hypertension control and how poorly you're doing in using the appropriate medications. So we want to make sure that whatever we do is really aligned through all steps of the organization. And we want to have visible high-level support. So if my medical center director locally is on board, but my national director says, I don't really think hypertension is a big deal. I think it's lead poisoning screening. Then that's really tough because we need to have visible high-level support. So that's the checklist. And so if you just do that, you'll be successful. No, not really. Here's the general timeline that we did. In 1995, and actually we had been doing this a little bit before then, we started to have clinical practice guidelines. And my group is fairly organized, but not as organized as you might believe. And we just can't tell the doctors, okay, you work for Kaiser Permanente, so therefore you'll be a bunch of clones, right? And just because I say, because we had 6 people decide on a guideline, it's the guideline, right? Next topic. It doesn't really work like that. There's a lot of consensus building back and forth, and we think that's a really important process, especially when it's transparent and it's inclusive and we validate people's fears and their concerns, because the last thing we want to do is the dreaded they, right? They want to use this drug first. They don't think this is a good idea. They think it should be 1 week, and I think it should be 5 weeks. We don't like this they, and we are quick to point out that it's we. It's no, this is our guideline, and we believe this drug should be first. So I think that now, to what extent that would be possible in a diverse set of groups, I'm not certain, but I know that amongst your groups, you could develop consensus around what we think in our group based on our interpretation of literature, our resources, the cultural aspects of the communities we serve, perhaps racial and ethnic variations in the drugs we choose. I am sure that you could come up with a set of recommendations that you would feel passionate about and could own. And I think that's an important part. We'll go over that in a minute. But that's what we started to do in 1995, and every 2 years we started to do that. Well, unfortunately, doing that alone isn't terribly effective. And in the old days, we would say we'd go to the offices and the guidelines were still in the shrink wrap. Now we send them out in PDFs now, but now the PDFs go out and they're not opened. But it's the same thing. Just having guidelines doesn't really do a whole lot. But I do believe it's important to know what it is that we should be doing. And then we developed a registry, and again, Dr. Penso and I were discussing this. I actually think this is the most important part, because if you don't know how well you're doing, who it is you're taking care of, how on earth can you monitor your progress? So I think these are actually the two most important parts. Knowing who it is you're supposed to care for and knowing what it is you're supposed to do. Pretty basic, but this is an awful lot of work, and many groups struggle trying to get this done because it's very resource intensive. It takes a fair amount of organization. But I believe that no group can be successful to a high degree of success. Up 80, 87% control like we have at Kaiser. I don't know that you can get that level without this and sustain it for a large group. I'm not sure you can hit and sustain that without registries and guidelines. And then kind of once you have guidelines, what we did is we started doing performance measure distribution unblinded. So we used to hide the doctor's names, hide the clinic names. We didn't do that anymore. We just send it out. We're not judging anybody. We put your name on it. And, it's going to happen eventually anyway, right? The federal government's going to put it on some website. So we might as well do it now. People might as well get used to it. And there's a lot of complaining and moaning about how it's unfair, my patients are sick, or blah, blah, blah. But what's interesting is that people say that, and yet we see a decrease in variation just by sharing the information. It leads to a lot of complaining, and I figure I'm like a piñata. Piñata kind of gets beaten to death but brings joy to the party. So that's my role, and I don't really care because it does improve hypertension control. So when I have to share these quality metrics. And then we share the practices. So, we kind of look at who's doing well, and we share it with people. And then we have practice efficiencies. And there's a lot of practice efficiencies, but I would put as practice efficiencies the introduction of early use of fixed drug combination therapies, which the name has been changed from FDC, which was fixed drug combination. It's been changed to SDC, single pill combination. So the literature is now going to have, if you're Google searching, you got to look for SDC, which means 2 drugs in 1 pill. And we'll talk about why we choose to do that. And then also some of the practice efficiencies is finding a way to take care of high blood pressure outside the traditional doctor office visit. And I'll show you some ways that we do that. But it's, I'm not convinced to measure a blood pressure accurately, does it really need a visit with a doctor, which is pretty resource intensive. And I think you could argue it might or might not. It probably involves the assessment by someone who knows how to take a blood pressure. And I would argue that medical assistants who are trained and monitored yearly and have practice assessments and competency assessments would argue that that may be more accurate than physician blood pressure assessments, because the physicians tell you they learned it in medical school, and that's good enough because their resident told them, and their resident before them, and their resident before them told them. And so it may be easier to have a consistency of practice in a group who has a more traditional, let's say, competency structure, such as medical assistants and nurses. So let's talk about the guideline itself. And I was talking a little bit earlier with some people here about, can y'all have a guideline? Why am I saying y'all? Thanks for having me early. I'm getting on a plane today at 4 to go to my 25th Medical School reunion in Houston, Texas at Baylor. So I'm kind of getting into the y'all words here. So although I'm born and raised in California, but I'm kind of getting used to that. So I'm going to have to get out of here as soon as I hate to miss the lunch and the conversation, but I'll have to leave as soon as I'm done. So we have what's called cascading sponsorship. And I think this is really important because you really have to know what it is that your end user wants. And there are some people who say, I don't really care what the guideline is, just tell me what to do. Is it a drug A, B, and C? Is it A, C, and B? Is it X, Y, and Z? And some people say, please just tell me what to do, and I will just do it. Right? You tell me, and then I'll organize my care team, and we will do it. And there are other people that say, now, wait a minute. Who said A was better than B? I think B is better than A. I think there's no difference. And because there's no difference, I think I, as the director of this patient's care, should, like a craftsman, be able to decide what the unique characteristics of that patient are and then decide. And I should be allowed to prescribe anything I want. And there are some people who believe that, and there are some groups who believe that. But when you talk about getting a large system of patients under control, it would be like building Toyotas one at a time, letting the workers do whatever they wanted to do, however they like to put cars together. And maybe cars are made like that, but I want my car rolling off the assembly line with all the checks and balances just like all the other cars, because I think they're made pretty well, Toyotas, Fords, or whatever. So I don't kind of understand why in medicine we don't act more like that, but we don't. So I think the guidelines are really a way for us to move towards more consistent practice. When you have passionate people, that's really good. I love when people argue about the guidelines because I know that they're engaged and they have they feel that they feel it's better than just seeing a bunch of blank faces or no emails at all. I love these nasty emails about how dare over my dead body will we not use drug A, and how dare you, don't you know about this study, what about drug B? But the key is to involve those people, because if you have a guideline, you don't involve any of those people, then when you start to roll it out, they'll say, now wait a minute, I don't like drug A, B, and C. And if you involve everybody too early, they'll say, why are you wasting our time? Just come up with a guideline and I'll do whatever you want to do. So I think that knowing who it is who you're presenting your guideline to and knowing what they expect is really important. If you involve them too early, they get annoyed, it slows the process down. Involve them too late, you have to do a lot of rework. And so I think the real challenge is to know who likes to be passively involved and who likes to be actively involved. And unfortunately, you need to know the attitudes, beliefs, and more importantly, the history of the groups. I mean, for example, in my group, one subspecialty group, the cardiologists are very agreeable. They're like, okay, you guys are really good at this. Good, we endorse it. But another group, the nephrologists, and these are both great groups, and they're like, no, wait a minute. We don't understand what happened to the ACEs and ARBs and why they're at this position, and we want to talk about that. And it took us a long time to figure this out, so we want to make sure that we involve them both, all groups, in the way that they want to be involved. And that takes a lot of years to understand who likes to be involved what. Now, a lot of people say, why don't we just take the Mayo Clinic guideline? Why don't we take Kaiser's guideline? Why don't we take JNC 8? Or JNC 7? JNC 8 will come out soon. Why don't we take the NICE guideline, right, the English guideline? And you can do that, but my personal opinion on that is that if you do that, you then are going to have to do unless your group is really an agreeable group and says, whatever, just tell us what to do and we'll do it, you may need to have some time understanding the guidelines, working through them, and kind of re-endorsing them. And if you start with that process up front, that endorsement process, that collective ownership process, I believe that's actually implementation. In other words, what you're doing is you're developing passionate support for that and ownership of that guideline. And that really is, even though you might bill it as guideline implementation, in my mind, it really is, you bill it as guideline development, it really is guideline implementation. Because if you don't do that, if you just say, here's the guideline, you're going to spend an awful lot of time explaining why it is and what you're kind of retreating, and then that slows down implementation. So I always kind of joke that we spend about 10% on guideline development and about 90% of our time on implementation. And I'm not sure that balance is right, because I think it probably should be like 1% guideline development and 99% implementation. In other words, it's really the implementation. But if you think that the engagement and the endorsement and the expanding cycles of involvement of this guideline development, if you think of that as implementation, then I think you'll be better off. So we have this very complicated process where we have to do both regional, statewide, and national consensus building, where everybody gets a chance to and we're very careful about the words we use. We used to say endorsement. Would you endorse this? But now we don't ask that. We now ask for people to review it. And then they can all review it. And then if we don't get any comments, you say, okay, everyone's reviewed it and there's no comments. Now would you endorse it? And they say yes. But if we say, would you endorse it? They're usually like, no, wait a minute. I don't like section 5.7J or whatever. So we're very careful. It's a lot of work, but ultimately everybody feels that they have a piece of the guideline as theirs. And so that's one of the underpinnings of this. And whether we do it nationally, statewide, regionally, or locally, or even on your team, it's really important, because when you start to organize systems, it's really nice to say that's what the guideline says. And when people say, we want to change something around, what we often say, the leadership, is that, well, let's change the guideline. Let's get everybody together, get everybody's input in there. And it's a slow process, but it really is a transparent and a robust process. And we're bringing the best minds, and it's really hard to argue with that. Some people don't like it, but most people do. I think all in all, it ruffles fewer feathers than having people just change practices on the fly just because they read some article someplace. So this is our algorithm, and I'm going to go through it in a sec. And you could argue that it's completely wrong and that you should use something else different, but I'm just saying we have an algorithm. And I want to compare this to JNC 7. Now take a look at this. JNC 7 says, with compelling indications, without indications, step 1, use any of this 1, 2, 3, 4, use one of these 4 drugs or a combination of those 4 drugs. So their first step is basically do whatever you want. Step 1, do whatever you want. Okay, so we looked at that, and because people say, how come you don't use JNC 7? We're like, are you kidding me? I mean, that's a bunch of smart people, but I think the people involved, I think the implementation people were sick that day when they published that, because I don't know how you implement that. And those of you that work in systems, and then you get chaos, right? Then you'll have a spreadsheet you'll have 10% prescription practices of all the drugs. And then also with compelling indications, without compelling indications, and then they say, here, look at this. It's the exact same. Diuretics, ACE, barbs as needed, but they don't say a combination here. So. And what they do for step 2 therapy, like the blood pressure is a little high, stage 2, they say use 2-drug combination for most. So if you look right here, it says, this is what JNC 7 says. They said for stage 2, use 2 drugs, and for stage 1, there's many options, including 2 drugs. So guess what we did? And we had to streamline something. What would you do if you saw this and they said, hey, Mark, how are you going to implement this in a system where the first step is do whatever you want? Is there one thing on there that you could do for almost every patient and be right for stage 1 and stage 2, which might improve adherence and might be an affordable way for people to get care? What would you start with? You'd start with combination therapy right off the bat. Boom, first drug. So that's what we do. First drug is 2 drugs. Okay? That's how we start. So we think we already got a head start on, not on other care plans, but a head start with the patient because we got them on 2 drugs. And why 2 drugs? And so we all actually say, okay, 2 drugs. And we'll go over this in a second, but why do we use those drugs? Well, what's the best drug for hypertension? Diuretic, right? They're the largest clinical outcome trial on the planet, or probably any other planet, I'd say in the whole universe, was the All-Hat trial. How many patients? 40,000 patients. That's a lot of patients. 10,000 got kicked out because they were an alpha blocker, but 30,000 patients completed it. There'll never be a trial that large. What did it show? Nothing beats a diuretic. So I don't understand why that wouldn't be the first drug and the only drug, and why on any spreadsheet that wouldn't be the vast majority. Yet I saw some spreadsheets today where they're here, both in my organization and others, where people might argue passionately that it should be an ARB, should be a calcium channel blocker, should be a beta, should be whatever. Anyway, so we think it should be an ACE inhibitor. And then what's the second best drug? Well, a little bird told me that maybe it's ACE or ARBs, and we'll see some data later where you could argue that maybe ACE or ARBs are historically or based on practice preferences a very popular drug. So if we say, well, if you use a diuretic and an ACE, then you've taken away the argument what's the best drug. You've got the first 2 most common drugs pegged. I always ask the medical students this trick question, so I'm telling you it's a trick question. What's the best drug to start for someone with diabetes? And then whatever the answer is, I say wrong, because I don't know any patients with diabetes whose blood pressure can be managed on 1 drug. And I think they're like unicorns. I mean, I believe in unicorns, and I think one day one will stroll into my office, but I'm still waiting. So the person with diabetes whose blood pressure can be managed on one drug is really a rarity. So the question is really, in diabetes, what's the third drug to use when 2 drugs aren't effective? Because many people with diabetes will need to be on a third drug. And the first 2 drugs should probably be a diuretic or an ACE-ARB, or an ACE-ARB and a diuretic. So we use them both. So now we've got essential hypertension and diabetes. What about chronic kidney disease? Well, should probably be on an ACE-ARB. Many will also need a diuretic. So we use that we use it for diabetes, for people with essential hypertension, for CKD. And so the only place we don't use this is for people with established coronary disease, for whom we think a beta blocker is important. So we just say, okay, basically that's what you do. We just use an ACE-ARB. And so we just forget about compelling indications. We should just use an ACE diuretic for everybody. Now, if you're going to get pregnant, probably not a good idea to be on an ACE or an ARB. So we move to diuretic therapy. So women who are potentially fertile, okay? So that moves over here. So we start with ACE-ARB, and that gets us a jump. About between 25 and 30% of all our ACE inhibitor prescriptions are written as ACE-ARBs in Kaiser Permanente. And I don't know how many of those are for heart failure or for proteinuria or whatever, but that's a lot. And the dose is very important. The dose that we picked was lisinopril hydrochlorothiazide, and we start with a 20-25, and that's very. And you would notice that one person raised my hand at a conference, and they said, "Oh my God, we would have to have 15 combinations. We'd have to have 5, 12.5, 10, 12.5, 20, 12.5, 40, 12.5, 5, 12.5, 5, 25, 5." And I said, "Oh my God!" I said, if it's up to me, if I was king." I'm not king. I'm running for king, though. If I was king, I would say, well, we'd only have one drug, and the rest would be not on our formulary. And the one strength would be the 20-25, because I don't want choice. I mean, some people only think that in the absence of evidence, there should be choice, and I think that they're really saying in the absence of evidence, there should be chaos. I think in the absence of evidence, there should be order and consistency. So why let people choose, like craftsmen, all these little time? And then your nurses and pharmacists and MA, everybody's going to have to learn all these doses. The pharmacy's going to have. So why not pick one dose, which is going to work for almost everybody, and just run people through that dose? And let me show you why we use this dose. 20-12.5. Well, we use a half tab, 1 tab, 2 tabs. At 2 tabs, that gets you to 40, 50, which is the maximum dose. Some people argue you need 50 milligrams of hydrochlorothiazide to really be effective. So anyway, that gets almost everybody up to the maximum dose. That's why we don't use the other ones. And so we give people the bottle, and we say take a half tablet a day, Mr. Jones or Mrs. Garcia, right? And you come back in a couple weeks, you have blood pressure checked. You could argue about when you have to check a blood test. And if it doesn't work, go up to a whole tablet. If it doesn't work, go up to 2 tablets. So how many bottles is that in their house for the 2 pills? 1. How many co-payments is that for them? 1. Do you think, what do you think, and I don't have any evidence about this, but here's my impression. When patients take 2 pills out of 2 different bottles and pay more, that might be polypharmacy. And when they take 2 medicines in the same pill from 1 bottle and have 1 copayment, that's only 1 drug. That's unipharmacy, monopharmacy. So I think if we're worried about patients' perceptions about being sick and taking all these pills, here's a way to get them on fewer pills. So last place I was at, they said, ooh, what about triple therapy? Well, there actually are some branded medications now which have 3 drugs in 1 pill. The logic starts to, the flow starts to get pretty tricky with that. We don't use a whole lot of that. And then in India and Spain, there's the poly pill. Y'all heard of that, right? So I think it's statin, aspirin, beta blocker, an ACE inhibitor, I believe. Might be something else in there. Maybe a calcium blocker. I can't tell. Can't remember. But anyway, they kind of have they have medium and strong doses. They kind of size you up. Say, well, you're kind of intermediate risk. Take this pill. You're high risk. Take that pill. And you know what? It works pretty good. But that's maybe one day we'll be and I'm not joking. Maybe one day we will be as forward-thinking as India and Spain and have that available in this wealthy country. But again, those pills with those generic affordable medications may be the way to go in the future. But right now we do a lot of this, fixed dose therapy. And then if that doesn't work, now just notice the half 1, 2. Okay, remember that pattern. So now If that doesn't work, what's the second drug we choose? We choose amlodipine. Why? Well, it can be split. That's the most important thing. It can be cut in half. It's effective, has few drug interactions. There's issues with simvastatin, but in general, it has few drug interactions. It can be split. Excuse me. It actually doesn't interfere much with the beta blocker if you use a beta blocker downstream. And you notice anything about the about a 5 milligram tablet? Does this look familiar to anybody? A half, 1, 2. So again, we're systematizing this. So we say, okay, here's the lisinopril hydrochlorothiazide. Take a half, 1, or 2. If that doesn't work, here's the next drug. We want you to take a half, 1, or 2. Again, moving that up through that system. And so now we've got 2 pills, 3 drugs, right? There are some people who won't be successful on that. And the third drug, and this really, I hope everybody's sitting down when I mention the S word, spironolactone. People, when you say this, people go, ooh, that sounds pretty scary. I think I want to use a beta blocker. But you can see more and more societies are really moving towards the upstream use of spironolactone in low doses. And the same people that are nervous about using spironolactone in low dose for resistant hypertension being defined as blood pressure not at goal on 3 drugs, one of which is a diuretic. That's one of the definitions. Then typically we use spironolactone. And, the funny thing is that people are worried about spironolactone in these hypertensive patients with very few comorbidities, yet who are the primary care doctors used to giving on? Well, really sick patients with cirrhosis or bad heart failure. So you just have to remind people, don't worry about it. These are low doses. You give them all the time to patients who are way sicker. Don't worry about it. Try it. And the reality is that it's far more effective than a beta blocker. And you can see beta blockers are really, we call it, kind of like the fall of Rome, the descent of the beta blocker. But you can see maybe 10, 15 years ago, beta blockers were, tied for first choice, beta blockers, diuretics, and they've been kind of drifting down. And in our organization, we use a lot of them historically, but we're not starting very many of them. We're really pushing away from the use of beta blockers. The docs are pretty comfortable with it. You don't need a blood test. But in terms of outcome, beta blocker is better than nothing. That's for sure, but it's not much better. It's probably not as good as many of the other things that we use. So, it's better than placebo, which is all you needed to demonstrate in the old days. So we use we're using a lot more spironolactone, and we're going to be modifying our guideline to change the order of the wording, because we think we're ready to say can use either, but we're going to put the words closer. Technically, these are a tie on our guideline, but we want to move spironolactone up a little. And I haven't used beta blockers for years as a third pill, fourth drug add-on therapy. So anyway, we all agreed to this. So you could argue that that's right or wrong. You might want to use an ACE, you might want to use an ARB, use something else. But again, the fact that we agreed to do this, I think, is really what's important. We also got registries. I know y'all have registries, because how are you going to know who you're going to take care of? And we take all the information we can find, and we stick it into registry. And the registry, it's flexible, and we can do things with it. We can sort it. We can sort it by height, I guess, if we wanted to, or birthday, or all the March babies, or whatever. But also comorbid conditions, last visit, future visit. And the more stuff you have in there, I think last count we had over 200 queryable variables. And what used to be static, in other words, used to be produced centrally and sent out, now we've got a version which is people can access if you have security clearance, and you can slice and dice it the way you want for your medical center. That takes the burden off us of always having to produce it for people. When's the next report coming out? When's the next report? So we have a process for this, and this is really useful. And the fact that it's you can modify it on the fly is really helpful. And then we'll talk a little bit about control rates. And again, just point out 2 things. One, it's quite a variation, 30 to about 42%. This is of our 17 medical centers. I'd also point out the year, 2001, and look at the rates, 30%. Highest control rate is 40%. So this is where we were 10 years ago at Kaiser Permanente. But even before we had an organized system, we did have quite a bunch of variations. So what do? We said, hey, wait a minute, what are you doing? And the funny thing is that, you know what they said they were doing? They said, I don't know. Isn't everybody doing this? I don't know what we're doing. So you can ask people what they're doing, and as a matter of fact, group number 1, you ask them what they're doing, and they go, oh, we have these great programs, and so, they're very proud. If you weren't careful, you had a meeting, you could say, who wants to share? Maybe groups 1 and 2 would share. So part of it is really a very deliberate process about, so what we do now is we go to groups, the central research group, keeps track of this stuff, and then we call up 16 and 17, and we say, hey, what are you doing? And they go, I don't know. And we might send a survey out, and they all check off the boxes, and usually you can't find it from a spreadsheet. We get all these surveys back, and sometimes people are using things and aren't using things. So it usually takes site visits. And when you get site visits, you get it's a pain. We have to drive, and Kaiser's pretty big. We end up driving all over. But then you learn about the culture, and you learn about whether it's this might be, for example, alignment of leadership and message. It's hard to find that on a spreadsheet. And they go, I don't know, doesn't everyone's chief of medicine think this is important and mention it every week? I thought everybody did that, right? So they're not going to, and you go, oh no. Some places it never gets in the agenda. As a matter of fact, it's not even mentioned. And it's not mentioned, and that's because it's really felt as unimportant. I mean, like merely mentioning it doesn't do something, but being so important that it's always mentioned, I think, is like a surrogate marker. So we have to go and find out what's working. So I would encourage you that spreadsheets are nice, but if you're really serious about it, you'll probably have to do some site visits and talk to your colleagues and have somebody or some people go to different places and get a sense of what is effective there. And it's nice because you get to meet people and build relationships, but it's hard work and it's very labor intensive. But I think without that, you won't know what actually makes a difference. You'll just have a very sterile piece of paper. It's continuous, so you have to do this over and over and over and over. So we, as an organization, do it every 3 months. We have big reports, but that wasn't enough for the medical center's process improvement, so now we have it monthly. We have this canned report, and they could get it daily if they wanted to generate their own report off of that list. But a monthly is enough so that they feel they don't have to go in there and manipulate it. We've got some programs that we can do. But 3 months wasn't enough initially. And then we have, and we continuously look at the landscape and try to find successful and useful practices. We have lots of tools. And I'll just point out that, just go over some of the tools that we use here. We have this, the pocket card, and so this is, and we've gone over into, but this is basically ACE. This is a combination ACE plus diuretic, and then a calcium blocker, and then beta blocker, spironolactone. But like I said, we're going to be moving the wording of this over a little bit. And then if you're going to get pregnant, then no ACE or ARB, obviously. So we pass this out. This is, I don't know if it's in the pocket. I don't know if it's a laminated pocket card anymore, because in the past 12 years we've moved, from tangible things to more virtual things, but we still see these. Like, I go into doctors' offices on my medical center and I see these crumpled up in people's pockets, or tagged up to the doctor's workstation, along with like the colorectal flow sheet. I mean, they have a lot of things to do in primary care, but this is often up there. We have some handouts, and I don't know about your pharmacies, and we have great pharmacies, but if you ever read what they give you, I kind of wonder, is this supposed to make the sheet that the patient gets you, is that supposed to make the patient want to take this medicine? Because here's all the things that could happen. You could drop dead, your hair could fall out, you could be struck by lightning, your tongue could swell up, blah, 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 blah. And so I think it's just, in the era of informed consent, every possible terrible thing that could happen is listed. Right? And that's what they get. And the law says that we have to do that, and so we do that. But we think it's not necessarily balanced. And if you've picked up a prescription lately, that's what it says. So we created things which we think are more balanced, which we hand out. Now, the pharmacy, still under the state of California law, is required to offer the patients all of that stuff, which they do. But we also provide them something which we think is a balanced view of risks and benefits. And we talk about something for lisinopril hydrochlorothiazide. And because that represents over 99% of our combination therapy, we have these in all the exam rooms. So you can imagine that if we said, like the JNC7 said, you know what? Combination therapy is a good idea. Use any combination that you want. Well, what kind of a handout would we have in our room? How could we make one? So this whole thing about consistency drives us to saying, hey, this is the one that we chose. And if we chose a different one, which I'd be fine with that. If there could be enough evidence to choose something different, okay, I'm okay with that. We would just pull these out and put a different one in. Suppose we decide it's hydralazine and clonidine. That's the latest thing, right? Suppose we decide that's what it is. Well, we could change that, and it'd be one form. And we could change the algorithm, we could change all the things that we have. Now, if we've got a jillion forms, it's harder. So we make these available, and these are used a lot. And part of it's because you go back, we've agreed what it is we're going to do. So you see, we couldn't do this if we all didn't agree what it is we're going to do. Otherwise, you have some generic thing. Hypertension is bad. Your doctor may have given you some pills, and you should take them. So people, they usually want more information than that. We have posters here also, and take what you need. So we try to put a positive spin on it, use these are models, and this is from our website. We try to use people who represent the patients we serve, proper age. So these are done. We have some consultants, and we have a lineup of people, and they say, no, this person, too old, too young, too thin, too heavy, too gray, not gray enough, wrong ethnicity. So we actually have people that work with us in focus groups and for patients to try to figure out what's the right image that we want to do to convey health, optimism, and control of your care. So this is also aligned. Most of these are themed in very similar colors too, so that they look kind of branded. So when we do pass out stuff to patients, it looks like they're kind of a set, as opposed to a bunch of Xeroxes of Xeroxes of Xeroxes, which was the old way that things were distributed. We have a website, and this is technically, you can go here, but if you're not in you have to check a button that says I'm licensed to practice in California. If you're a patient, you can go here, but if you're a doctor, so I don't know that anyone scrutinizes this, but we're really not supposed to be practicing outside of California, right? Because we're a California health plan, so there are rules that say that we can't be treating patients, we can't be, soliciting and treating patients outside of California. So this really is for use in California. So for doctors and nurses and care practitioners that use this, there's a little box you check that says I'm authorized to state to practice in California. Now we actually can look at the hits on this, and we know, you can look at the hit use, and we know where the clicks are coming from. And believe me, they're not all from California, but that's what the disclaimer says there. So, but any patient can do this, and it just, again, is aligned with what we do. We also have a lot of support systems. We have medical assistants and things we call panel management assistants, and I'll go over this in a sec, as well as some tools and things that other people have as well. This is what we do, and I was talking, this comes up a lot in a lot of venues. We created a new role, and this was created actually in Richmond, California, a place where they had traditionally difficulty with staffing, and it was one of our most challenging care sites. And so probably one of the most important innovations came from a passionate group of doctors working in a difficult socioeconomic environment. And it was so successful that we brought this out and used this in all of Kaiser Permanente. But what they did is that they trained medical assistants to have good phone skills and to be able to pronounce the names of the drugs that were frequently prescribed, and to know that which drugs were ACEs and ARBs and the trade and generic names. And that's perfectly within the scope of practice in the state of California. They're not making assessments. But if the medical assistant called up and said, "This is Sheila. I'm calling on behalf of Dr. Jaffe. He wanted me to check in with you, and he notices your last blood pressure was high 3 weeks ago, and he wanted me to check to see if you're still on your lisinopril and your hydrochlorothiazide." And if the patient says, "No, I'm on Prinavil or Prinazide or Aldactazide or Zestril or Zestiretic," we would want the medical assistant to be able to say, "Oh, yeah, well, that's a different name for this." And that's not an assessment. That's just knowing the vocabulary. So having our medical assistants be trained in some of the common names, be good on the phone, and to say, "Well, that's really important. Now, Dr. Jeffrey really wants you to take that, and I can see that he had asked you to take these medicines, so I want you to work on taking those, and he wanted you to come in and have a blood pressure check in a week or two." Again, so this is really delegating a lot of the work outside of the traditional doctor office visit. So we did develop some special trainings for the vocabulary and some of the phone skills. And also we developed worksheets, which might be 10 or 20 worksheets. And these are not only for hypertension, they could be for diabetes, heart disease, but they're primarily for hypertension. And you might get your list of, we would generate a list from that registry of 10 or 20 patients that each individual doctor would have who needed some work. Maybe the blood pressure was too high. Maybe it was too high. They weren't on a diuretic. Maybe they weren't on anything. Maybe there's a pharmacy refill We track the refills, there's been no refill. You can imagine anything it would be. The list would be teed up. The medical assistant would meet with the doctor for about 10 or 20 minutes. We invented a new verb. It was called tooling the patients, because this thing is called a tool. And they would say, how many patients did you tool? I tooled 15 patients, whatever. So, but we would tool the patients. In other words, you meet with your with your medical assistant, do a check-off list. Excuse me a sec. And decide, okay, Mrs. Jones, okay, she's got her blood pressure checked. Mr. Smith, oh, looks like we need to double his lisinopril hydrochlorothiazide. Mr. Johnson, oh, let's add nifedipine, or let's add amlodipine, et cetera. And so the medical assistant would then call and say, oh, I just met with Dr. Jaffe, and he asked that I convey this message to you. He wants to do this, this, or this. And could you please come back in 2 weeks, and I'll check your blood pressure. So again, it's this cycle, and it's under the direction of the primary care doctor. It takes place on the primary care team. It's not someplace that's foreign. And we don't charge the patients for this because it's just part of what we do to control their blood pressure. They see the doctor whenever it is. A lot of people go, how do you bill for that? It's like, I don't know how you bill for it. We take people's money at the beginning of the year, and we're supposed to take care of them. So the VA could do this, Kaiser could do this. If you have to bill for it, you have to think of a way how you're going to charge. But it's not about charging patients for the service. It's about taking care of the patients. And really, do you need to come back and see the doctor 2 weeks after there's been a minor adjustment in medication? Maybe you do, maybe you don't. So we find that patients like this, it's less cost for the patients, better access, because we have the medical assistants on the teams, have a schedule of about 15 or 20 slots where people can just come in, sit in a quiet room, blood pressure is checked. If it's too high, they wait a few more minutes. We have these protocols, train the docs. And then if it's real high, the medical assistant bugs the doctor, hey, Mrs. Smith's blood pressure is too high. If it's a really bad day, the doctor says, I'll just call her later. If it's not that bad a day, the doctor might make a change on the fly. So we do a lot of this cyclical change outside the traditional doctor office visit. And we do ongoing tracking and monitoring. So this is a big part of what we do. And this, I think, is a big part of our success. We also have in-reach, which is something which means that outreach, and everyone knows what outreach is, right? Outreach is right the minute after somebody left and we should have done something, we go try to find them and remind them there was something we just forgot to do for you. That's outreach. And in-reach is the opposite. In-reach is they're here, and I've got a million things to do because you have your own agenda. Back pain, warts, toenail problems, depression, stress. But we also know about your unmet needs. So we have what's called an in-reach tool, which is basically, it's an outreach tool that we just fire, that we trigger at the time of the visit. Right? Because why would you wait till someone just left your office to realize they need a mammogram or their blood pressure checked or a cholesterol screen or whatever it is that they need? So we developed an in-reach tool for hypertension which said, wow, this blood pressure is high, and so are the past several blood pressures. Because one of the issues that we had was people would say, well, it's not too high. Why don't you just come back and we'll just repeat it? So we thought, well, showing people that, hey, this is high and so were the last ones. And in other words, hey, practitioner, this is the repeat blood pressure. Been there, done that. Now is the time to make the intervention. So we developed an in-reach tool which says this and several other blood pressures were high. We didn't say you must treat, but this was a gentle reminder that, you know what, this is the result of the check and check and check. This isn't the time. This isn't the time when you should be saying, why don't you just work on things and come back and come back. So we find that this in-reach tool helped us for hypertension. And just talk a little bit about the results. This is this is all public domain stuff. This is from the Commonwealth Club, and this is on the web from McCarthy. And this just looks at our hypertension control rates from 30, and all these numbers are slightly different, and you will know about this, whether you look at commercial, whether you look at Medicare, whether we look at our own, whether we exclude people with 11 months continuous enrollment, blah, 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 blah. So there's lots of different ways to do it. What we typically use is our commercial rate, because that's what I'm going to show you in a few minutes, because that's what's compared amongst health plans. But, there's other rates you can look at also, and we're obligated to take care of all our patients, not just the ones who are reported on a commercial rate. And I'm not actually sure if this was our internal total rate or our commercial rate, but I'll get you our commercial rate later. But the point is that it went from about 40% to 80%, so basically doubled. That's the message here in 7 years, when we did all those processes. This, I know Jerry has seen this, but this was shared recently at the Right Care Initiative in October of 2012, and the 90th percentile for hypertension control is 76%, and this year we're at 87%. Southern California is 85%, and the rest of California are here. So we're 10 or 20 points above the highest, the next California group. And nationally, Northern California is third. I don't know much about these other groups, and I don't know whether or not they're consistently high, whether there's a lot of variation. At least in our groups, there's not a lot of, we're so big, there's just not a lot of statistical change. It's like trying to, turn a battleship around. We can't brake or turn, accelerate, decelerate very quickly. So our rates are pretty stable. But these people might be doing something also, so I'm really curious about what Coventry and Cigna Healthcare Mid-Atlantic are doing. But you can see that a lot of the Kaiser groups here nationally are doing something similar. So Northern, Southern California, Hawaii, and Mid-Atlantic. So 4 of the top 6 are Kaiser Permanente groups. And we all practice quite similarly. We all more or less do the same thing. There's a few little wrinkles on it, but we do this. And when I talk about a national guideline, we all share the national guideline. And many of us believe sharing this national platform really drives us down to this implementation program. It really is the underpinning that we use. And then here is some information which was published in abstract form. And again, it just points out that, again, we had 44% of our patients in 2001, depending on which metric, what month you're checking and which metric you're using, and going up to about 80% here. And this is in 2009. And you can also see that the number of people with hypertension increased from 400,000 to 650,000. And that's based on as we became more attentive to it, we identified more patients, because also we talk about that hypertension is probably underdiagnosed. And the comforting thing is that this number right here is approaching about 25% of our adult population, which is right about where NHANES says you should be. 27% is what the national surveys show would be the rate of hypertension, and that's independent of health plan status, independent of anything. Or I think it excludes institutionalized patients, but that's where they just do surveys of people, and they just go out and find out who has hypertension. So we think that back here, in 2001, our rates were only about 12%, so we think we hadn't been identifying everybody. So when we have a big campaign to treat hypertension, you identify more hypertension. And we didn't actually have a hypertension identification campaign, but I think rising tide lifts all boats. And so when you start generating a lot of interest and activity around hypertension, then people are coded and people are sought, and so we think this is a much more accurate percentage prevalence of hypertension than what we had before. And so we do all this, and so in conclusion here, we're getting close to the end, you can see the control rate, it nearly doubled from 44 to 80%, actually, and you could say it went from 30 to 87%, so you can pick whatever numbers, but it approximately doubled. Our registry went up a ton, and the number of people with controlled hypertension went up from 171,000 to over 500,000 people. That meant that about 1/3 of a million more people had controlled hypertension. Now, maybe they had controlled hypertension before, we just hadn't documented it. It's fair. It's a fair assumption. You could say, hey, Mark, all you did was find people who already had hypertension, and you just coded them as having controlled hypertension. And I don't think we did that, but that could be a fair criticism. But then I would just point out this. That during the same point of time, we also published in the Journal of Medicine that the rate of myocardial infarction in Kaiser Permanente Northern California is falling, and this is in the time when the sensitive troponin assay is picking up more. So if you sneeze, you have a troponin leak, you could have an MI, right? And we know how that works. So again, you can see how the rates of overall myocardial infarctions are dropping, and the non-STMI, right, troponin leak MIs going up right in the early 2000s when sensitive cardiac enzyme testing is really prevalent in emergency departments. But the tombstone MIs, and I remember in medical school, we would see these tombstones come in, you see the T waves, really awful looking T wave, call them tombstones. And we don't really see many heart attacks like that. We just see these troponin leak heart attacks now. It's unusual to see a bad ST segment elevation MI. And we think a lot of this is due to smoking, cholesterol, but probably hypertension, because we have not cut in half the smoking rates. We have not doubled the dyslipidemia control rates. What we have done is cut in half the rate of uncontrolled hypertension. So that's what we think all this hard work can accomplish. And it didn't just take me. And I probably did of all these people listed up here, I'm the one that probably did the least. I'm just talking about it. But the people that actually did it, I think, are the 7,000 physicians and the other members of the Permanente Medical Group who treat 2/3 people with hypertension, as well as a bunch of my other collaborators here. So here's some references, a selected group of references, which I've included in the slides here. And like I say, all this is public domain. We hope to have a publication soon with some other slides, but I can't really discuss that. So that's what we do, and I don't know if any of it's going to be useful for you. Hopefully some of it will be. Hopefully not all of it, because I know we don't practice in the same care setting, but I'm really happy to share what we do, and I think we all share a mission to decrease the burden of cardiovascular disease in the communities, and a really good way to do that is to deliver high-quality, effective, consistent hypertension care. So thanks for listening to me, and I'm happy to stick around for the next hour or so, or as long as you'll have me to look at data and answer questions. Thanks so much. Jerry, how'd I do on time, Jerry?
Perfect.
Okay.
Right on. Any questions?
Yeah, I'm wondering about home readings. Do you emphasize those? People getting their own cuffs and checking at home?
So the question, and I'll repeat the question so everybody can hear. The question is, what is the role of home blood pressure monitoring? So we characterize that in two ways. Ambulatory monitoring, which is when you take the 24-hour device home, and periodic monitoring from a accredited blood pressure set that you have. And we use them both. The 24-hour ambulatory glucose monitoring we use, but we use it hardly ever because we believe that it's costly and adds very little to traditional care. So we do not use ambulatory measurements, but that's like the Holter monitor for blood pressure. However, the home blood pressure monitors we use exactly like we use spirometry and home blood glucose measurement. Spirometry for asthma and home peak flows, and glucose monitoring for diabetes. It helps our member know what their blood pressure is. And I personally do make changes if someone tells me my blood pressure, I just started the amlodipine 5 milligrams, half tablet a day. It's been 2 or 3 weeks. My blood pressures, they're still 175 over 95. Well, of course, I'm going to say, why don't you just go up to a whole tablet? However, Kaiser Permanente and no other healthcare organization is permitted to record a blood pressure measurement taken outside the clinic as a blood pressure reading that counts for measurement, right, on any of these NCQA HEDIS guidelines. And I think that's appropriate because we think the gold standard is a blood pressure measured in a controlled environment by a medical professional entered in the medical record. So what we tell our docs is that, sure, if your patient can take the blood pressure and not a wrist monitor, not something they got on TV, but we actually use, I can't remember the name of it, but NICE, there is a group, a technology group, international technology group which certifies blood pressure measures. I think it's, I can't remember, Amatron or Armatron. I can't remember the name, but we use one in our, what's it called? Armron, yes, that's it. So we use Armron, and that's got some national and international accreditation for validity. So that's the one which we sell in our health education. So we only have one product, and that's the one that's nationally, so that we encourage that. Some people say I have a wrist one or a finger one. We're like, well, I don't know about that. But we use this one. And if some people bring it in, and sometimes we calibrate it, but we usually just have people send us the readings, and we might make judgments based on that. But we do tell people, if they say, all my blood pressure readings are fine, we say, well, why don't you just come, that's great, I'm glad it's fine, why don't you just come in a month to one of these non-physician doctor office visits, and we'll just document that. And it turns out that non-doctor office visit does count, because that's done in the clinic, in the primary care team. So actually NCQA does count that. So when we think that, we have some control over that. So we use it a lot to help titrate, but we don't use it to assess control. But just like we would, the A1C is the gold standard, right, for diabetes. You got to have an A1C. But if a patient tells you their blood sugars are all over 200, you might have your clinicians make an adjustment. But you're going to want to know what the A1C is periodically. Does that answer your question? Right, hardly any ARBs, hardly any ARBs. And so some people say, well, ARBs are the same as ACEs, except there's less cost. And we say, okay, but we're trying to find, and we've been doing this for 13 years now, and it wasn't until the past 2 years that we had an affordable ARB available for most of our members. Now there is generic losartan, right? So now it turns out that although there's generic losartan, there is no combination, there's no generic combination diuretic ARB which has a high enough diuretic when adjusted to get you to what we think is an acceptable max diuretic dose. In other words, there is and again, this might change, but the last time we checked, there is a losartan hydrochlorothiazide like 50-12-125, and we think that can't get us up to the dose. Our experts, and again, I'm not an expert in this, but I'm an implementation person, not so much an evidence person, but I'm told that the combinations we have don't get us up to the maximum dose of diuretic in a combination pill. But when patients cough, listen, if they have angioedema or hyperkalemia, we're not going to use an ARB. But if they cough, then we say, okay, you could use an ACE, and then use an ACE and an ARB separately. But that's, but only about 5 to 8% of people cough on an ACE inhibitor, depending on what clinical trials you look at. So we do give it by exception, but it's not right out of the chute. And if we could have an affordable, effective, appropriately dosed ACE ARB, something we might ARB diuretic is something we might consider. But we try to keep, we want to make sure the value is high, and if our patients have to pay a higher copayment for something, and we're not, and it doesn't even get us the right, doses to get where we want to get them, we probably won't do that. But again, but I would point out that only 30%. So of all the ACEs, 30% are written as combination ACE diuretic, which means 2/3 aren't. And so not everybody does this, but say 7-8 years ago, it was 0% or a fraction of a percent. So we've gone from 0 to about 30% in about 6 years, and it looks like it's staying steady at about 30%. And I don't know if it should be 90%, or I don't know if that's the right number or not. We were talking about data earlier. I don't know what the right number is, but that's what it is. Kind of went up for about 3 or 4 years, and it's now at like 27-30%. Generally these numbers, doctors can do whatever they want to do. They can do whatever they want to do. But I can tell you the prescription patterns are probably 80% are amlodipine. Okay, probably 80% amlodipine. The diuretics, probably 90% is hydrochlorothiazide, maybe 8% chlorthalidone. The ACE inhibitors, probably 95% lisinopril, a little bit benazepril, captopril, and allopril. And the ARBs, when used, and these are, as they become more affordable and there's more data on them, but that's probably 80 to 90% is losartan. So in our system, again, it's hard for the doctors to use something else and the patients to. And I'm not saying we make it hard, but we make it easy to use the one which is on the flow sheet, which we have the patient information field, that the pharmacy is going to have, that all the other covering doctors are going to know about, that the medical assistants are going to know how to pronounce. So it's not that we're preventing people from prescribing off the protocol, but we're making the right thing the easiest thing to do. And we think this is the right thing from a system approach. But of course, if your patient needs hydralazine, clonidine, and reserpine, sure, you could prescribe that. You know what? Why don't I have someone else help me with I don't want to play favorites, so I'm going to have you be the question master?
I will.
Okay, thank you.
Microphone around, so
Thank you.
So I would like to first say that your work here is nothing less than inspiring. So I really congratulate you. This was so impressive. But my question to you is a couple of questions. One is, how do you decide whether a patient is under control or out of control? I see that you have 87% or whatever of your patients are in control.
So this, and we have a publication coming out, and this was a source of great debate, is what is control? And so control is, I don't know what control, let's be honest, I don't know what control is. But in order to compare apples to apples, we have adopted, for use in our publications, the exact same measurement that HEDIS NCQA uses, which is as following. And you can just Google search and pull it right out of NCQA HEDIS, and you all should be able to recite this. It is the last blood pressure taken at a visit, not in an emergency department, hospitalization, or institution, not for the exclusive purpose of a procedure or surgery. That is what NCQA HEDIS uses as control. So, for example, here, when I do this, and we debated this internally, what's control? This and this. That's what's reported publicly. So we feel we have to report this because that's what we can't say, I actually know what our numbers are when we use different things, but when we use people who aren't continuously enrolled for 11 months, because that's who's here, this also, you actually have to have a diagnosis in the first 6 months of the year and then a follow-up blood pressure either in the first 6 months or next 12 months. There's all these funny NCQA HEDIS requirements, but I can tell you in a publication we're going to do, when we look at another way, the only difference that you see in our rates is less variation because HEDIS samples. So we have 650,000 people with hypertension. Would anyone like to guess how many patients we sample for the NCQA HEDIS survey? Yeah, well, let's take a guess. Anyone take a guess? I want to hear a guess. Remember, we have close to 1 million patients. So how many patients do you think these numbers are based on? Did someone say 250? That's right, 250 patients. So when we look at the numbers, though, so what we see is we see the p-values go like this. So it turns out these numbers are very close. There's not a bias high or low. We just see hardly any wiggle room in the curves. Because when we talk about control, like moving a battleship around, right? So it's a great question, but we just choose to report what everybody has to report. So that means if your blood pressure was sky high all the time and the last blood pressure was normal, then you could be spuriously controlled. If it means all the blood pressures were normal and then you were seen in the urology clinic, which technically is part of our clinic because we're a clinic, then it could be high. But it turns out 90% of the blood pressures are taken in primary care. And so the primary care doctor is going to worry about us all the time. But it turns out this data, this is actually pretty good. And the reason why we check it is because, frankly, we don't really care what NCQA says. We want to control hypertension in our members. So who cares what this says? And if the numbers are wrong or gamed, that doesn't help anybody, certainly our patients. So it turns out the only difference is that there's less variation when we look at it. And, you could argue against, what NHANES says hypertension control is? So we have these debates. NHANES says, here's what it is. You take a trailer and you drive it out someplace and you invite people from the community and they have 3 blood pressures taken by a skilled person. And you take 2, and if the first 2 are off by a certain amount, you take a third and you average them. Now, I don't know about you, but I don't know anyone that does that in their clinic. So, what we figure is that, and then actually Kaiser, Joel Handler in Southern California, published a paper about if the first blood pressure is high and the second blood pressure is low, what does that mean? Because a lot of people do that. It's high. You say, Mrs. Jones, just settle down. I'll check it again. That's what happens in clinical practice. Is that good or bad? So there's some literature that, in terms of regression to the mean and how much change you can expect, and things called reclassification. That basically blood pressure. I think the HEDIS measurement, as crude and simple as it is as good as any other measure. So we just use that. Long answer, but we have this debate inside. And some people in Kaiser think we should use something else, but we're just doing this so that we figure we'll get less heat if we do this, because we'll report what everybody else is reporting. If we reported something else which we think is better, we'd get a lot of heat. Sorry.
A quick question. You may have mentioned this already, but do you track drug discontinuation rate for side effects and intolerance, for example, the Cenopril?
Sometimes. So the question is, what's the, what about discontinuation rates and side effects? We have done a little bit of this, but not for hypertension. And for example, we have a program for for our secondary prevention program, which is, so hypertension is about 27% of our population. Our secondary prevention program, which is basically heart disease, diabetes over age 40, strokes, TIAs, and PAD. That's about 12% of our population. On those patients, we have a little bit more rigorous system. And for patients who are not on a statin or an ACE inhibitor, we have some programs where we have a pharmacist who calls them up and tries to figure out why it is that are not on a statin or an ACE, because those patients we want on those drugs, actually in a beta blocker too, and we keep bugging them and calling them. So as a practical matter, we said, well, if a patient had angioedema or hyperkalemia, then we don't want to keep bugging them, but if they just had a cough, we want to switch them to an ARB. So we do this, but not for the general hypertension patient, and we don't do it consistently. So I don't know, I don't know the actual rates, but we do it in a limited fashion.
With all the prinazide and spironolactone you're prescribing, have you considered protocolizing the, potassium and creatinine checks?
So the real question is, so the issue, I'll reframe the issue. That is, what about hyper and hypokalemia, hyperkalemia? Because you're pushing out a lot more drugs, and you could potentially get a lot more hyperkalemia. And the nephrologists will tell you, yeah, we're seeing hyperkalemia in the ER. Okay, now we monitor this. We think they're more attentive to it. We monitor and track it. We don't see any change. We see a reduction in heart attack and stroke. We do recommend that I frankly use, I'm an endocrinologist. Patients with type 4 RTA and diabetes whose potassium is 5.2, I'll give them ACEs. I just watch them real carefully. I'm comfortable with that, and some of the cardiologists and nephrologists do. But for bread and butter general practice, what we recommend is not using spironolactone. Here, I'll get you right here. When the GFR is under 60 or the creatinine is over 4.5. I'll show you this right here. It's a little footnote. And I think it's a little bit of a, yeah, here it is. So I think it's a little bit of overkill, but this is the safety check because we are a little concerned about that. So, some things slip through the cracks. We don't have a monitoring system. Kaiser Northwest published kind of a what-if trial. What if people start an ACE-ARB with normal renal function and you don't check a potassium and creatinine? How many people are admitted for renal failure or hyperkalemia? Because the textbooks say anybody started on an ACE-ARB has to have a potassium checked in 3 to 14 days, right? Well, the answer is it's no more, with normal renal function at baseline, it's no more likely than placebo. In other words, if you saw your doctor and weren't given any medication, the likelihood of seeing in the ER for hyperkalemia is the same risk as if you have normal renal function, were prescribed an ACE-ARB and didn't get something. And that's because in someone with normal renal function, it's low risk. So we use that clinical trial from Northwest to say, we're not worried about it that much for low-risk patients. I would agree that as the GFR falls, it's a little dicier. So we haven't encountered it yet. But, anecdotally, people do say that they know. And I think, if you give out more statins, you're going to see more rhabdo. It's rare you're going to see it. If you give out more ACE inhibitors, you're going to see more hyperkalemia and angioedema. The question is it worth it? Are you making it as safe as you can? Is it worth it? And I think it is worth it, and and it's pretty safe, but we could still be safer.
I recognize beta blockers aren't as efficacious as other antihypertensives, and you have them as a third line. I was just curious as to why, or was there a reason you chose atenolol over other beta blockers in your algorithm?
So why atenolol versus, say, metoprolol, bisoprolol, and most recently carvedilol? Basically, so the beta blockers are getting a bad rap in general. There was an observational trial from Kaiser, Colorado, of about I think 300,000 or 400,000 patients, published 2 years ago, which looked at. So again, we do a lot of our internal research, and this is published. looking at by Magid, M-A-G-I-D, and he's actually speaking at the American Society of Hypertension coming up in a couple weeks, M-A-G-I-D. But so he looked at the Kaiser, Colorado experience, and it's not a blinded randomized trial. It's just the rate of adverse events, particularly cardiovascular endpoints, in the use of atenolol versus all other cardiovascular. I don't remember if it's atenolol versus metoprolol or atenolol versus everything else. And at least in that trial, they saw no difference. And that was, observational. You could say there's selection bias. And the second reason, so one, we have internal data to suggest that it doesn't appear to be worse. And the other thing is that the add-on drug, the largest antihypertensive trial done on this planet or any other, the all-hat trial, used as an add-on drug atenolol in all 4 arms. So for those people that say, I don't think atenolol, I think it's dangerous, we go, okay, well, that's what they use as, first of all, we're not talking about atenolol monotherapy. We're talking about atenolol add-on. So there's no data for atenolol add-on. We're talking about atenolol add-on therapy. There's only one trial where it was used systematically, and that was the all-hat trial, which showed favorable clinical outcomes. And you could argue, well, but if you used metoprolol, it would have been better because there wasn't a head-to-head beta blocker comparator. But when you start to talk about combo stuff, you're starting to get out on a limb. So those 2 reasons, I have to be able to stand up and defend it. And it might be, and there are some people who just hate beta blockers and hate atenolol. And so I would say, if you guys, or you men and women, in your place, if Roseville or Atlanta or Sacramento, you think that it makes a difference, I'm okay. That's great. Then use metoprolol. But I don't think there's a big difference, and we just have a lot of atenolol out there, and to change a guideline, unless there's a really big reason and get people on and off it, we think, man, is that worth it? We'd rather start talking about spironolactone and how important that drug is and how you ought to use that in a safe patient. And, the beta blockers, turns out, if you trend beta blocker use, and I suggest you all do this, they're kind of going away. It's kind of like pioglitazone. You can you can try to get people off pioglitazone, but if you just look at pioglitazone prescription rates, I know it's for diabetes, they're just kind of going away anyway, so I'm not sure, at least in our organization, except labetalol. Or carvedilol. Yeah, now carvedilol, remember, no endpoint outcome trials for hypertension, so it's some surrogate marker ones. So, it's the new kid on the block, but it's not, it's a combined alpha and beta blocker. So, but it might be useful, so you could use it or not. And it's hard to know. I think what's more important is that you guys, everybody, that you pick something and just implement it. Because frankly, let's suppose that you had clonidine, hydralazine, reserpine as 1, 2, and 3, and you effectively implemented it, and you got everybody on it. Probably your heart attack rates would go down, I would think. Now, you could argue it's cumbersome, there's side effects, but if you did it, so I think even if we pick the wrong drugs, we're still going to have great outcomes because we're organized, and we're trying our hardest to actually pick the right drugs. But just because we don't know what the right drugs are, we're going to systematically pick something and go with it, as opposed to saying, well, we don't really know, do like JNC7s, like first drug is whatever, and second drug is a combo. So that, thank you very much.
Okay, any more questions? All right, well, thank you very much, Dr.
Oh,
Jaffe.
thanks
that
a
was
bunch.
a very excellent presentation. You're unhooking? Great. I'll put it on the chair right behind. That way it's more space. And then depending on how hot we have to 11:45, I can always put
Let's see if this works. There we go. So I think John Hines said it best. That was inspiring. I really appreciate that. And what we said we'd do is look at a little data. And since Dr. Jaffe has agreed to stay around and help us sort of think about this, I thought it might be good to go through just a few things. This is not highly organized or highly planned. It's really just looking at some interesting bits of data. Again, trying to spur discussion. And we'll follow this, of course, with a network luncheon. So the whole idea of being able to have this to talk about, I think, would be interesting. So what we've said for the Measure Up, Pressure Down campaign is that we will follow JNC 7 recommendations, and soon we know there will be some JNC 8 recommendations, and they may well be different. So we're trying to be a little vague about exactly how we're going to measure this. And as you said, Mark, I think the fact that everybody is having to report the HEDIS measures, NQF 18, with all of the specifications around that. That is the one thing we're going to require. And we'll talk more about this tomorrow and get some more feedback from you. But I think we're thinking exactly the same way for the campaign. Even though we've said JNC 7 is our goal and our target will be measured in terms of JNC 7 control. I think the fact that the world is reporting, whether it's for meaningful use or for HEDIS or for whatever, the world is reporting NQF 18. We'll go with that as the required, and then add a layer of optional reporting if people are able to and want to do that. So here's how the population breaks down. If we just kind of look across all of the NSETA participants, the population breaks down to about 40% are uncomplicated or complicated. They have either CKD or diabetes or both. And yes, we are including Humedica's detection of patients with diabetes who may not have a code. So that's something a little different, but we probably ought to at least know those patients are in the population. And also CKD, we are looking at consistent measures of low estimated GFR. And it turns out that there's enough variation in the creatinine levels that are used for those measures that it's kind of hard to make sure you're consistently low GFR. But at any rate, so we are taking the kind of broader view of both of those categories. And here's kind of where things are historically. So for the uncomplicated patients, the current overall control rate by the JNC 7 recommendations, and of course this would be higher if we were holding everybody to 140 over 90, but for JNC 7 it's 64%. And for the complicated patients, it's 40%. So we've got a long way to go on the patients with diabetes and or CKD. If we stick with this, but as I said, the reporting guideline we're sort of following is the HEDIS guideline and the NQF endorsed measure. One of the things that's interesting, though, regardless of exactly which measure we're using, is that we are seeing in all of the groups, we are seeing a gradual improvement in control. And I think that's an encouraging thing. If you look at what we've got up here, this is overall for all of the medical groups, and then we've got the 21 medical groups here. And you have the codes. We do these by code, but you have the codes, and actually in this particular slide, since we're displaying it inside the collaborative, we do have the names as well, but they don't fit very well, so you have to sort of work from the first few letters. But at any rate, what we're doing is we're looking at all of the patients who were seen during 2010, all of the patients who are in the hypertension cohort, age 18 to 85. We're looking at control by JNC 7 criteria, but we're looking for the patients who were seen each of the 3 years. So they had to be seen in 2010, same patient seen in 2011, 2012. So there obviously are more patients being seen as time goes on, but these are the folks who are being seen repeatedly. So how is their control being followed? And as it turns out, we start out with overall 50% control. And then we get up to 55 and then 57. So there is, and you can see group by group, there's a little variation here, but at least things are beginning to look like they are improving. We use the standard of HEDIS that if you don't know it's in control, then it is presumed to be out of control. So if something is not measured, meaning these patients actually had a visit, they have hypertension, they have a visit, and we don't have a recorded blood pressure for them, then, and you can see that the number of patients for whom that is true is going down. So we're doing a better job, as we were talking before about the process measure, of making sure we get things measured. One of the interesting things is I think you begin to see a little bit of an effect here that some of the improvement in control is actually, it's not a reduction so much in this 40 or 41% of the patients who are out of control, but it's just the fact that we're measuring more people. Now, people could be coming in the top of that brown bar and out of the bottom of the brown bar, so we're not saying it's exactly the same patients, but, it's good that we're doing a better job of measuring, but we're not doing a very good job overall, anyway, of reducing the proportion of patients that are out of control, out of the entire, this group of patients who are being seen over the period of 3 successive years. So I think the challenge here is for us to, as a collaborative, figure out how we can work together. And it can be us. I think Mark, you really focused very much on we can have lots of expert committees within each of our medical groups to decide which is the best thing to do, but then there's this phase of implementing it and making sure it happens. And that is, and a lot of us are the people who are sort of charged with that role, and we are very willing to work with the data and explore the data with some committees of the experts. So if you have people who are interested in hypertension, whether they're nephrologists, whether they're cardiologists, whether they're whatever, that want to work with us to understand the data to inform your guideline and approach, we can do that, but then we still have the issue of how are we all going to help each other with the process of implementation, of making sure things happen consistently. And you can see, I should mention here that we don't have complete historical data from all of the groups. So this is Aurora's data from a couple of years ago before the groups were on. And we'll talk tomorrow about some subsets of the data where we have very consistent measures. But here is, interestingly, the blood pressure control at the last E&M visit for complicated patients, just showing by medical group, there's the missings, there's not in control, there's in control. We have medical groups that where there's a difference of 38% control, and that's pretty close to the overall, but then we have some medical groups that are up at 52% control. So there's, 16% there, and then another 28% to go. So a long way. These are complicated patients. This is the one where we have to double our overall control rate. But there's a lot of feeling that there's probably something we can learn from each other about this and then work together on the rest of the way. This is looking internally within one of our medical groups to see that there's that 28%, there's that much variation from one of their sites of care. And these are all sites of care that have fair numbers of patients being seen in a given year. You can see there's 600, 2,000. This site has 7,000, 4,000. So these are large sites of care within this single medical group. So a lot to learn from that as well. And as you said, Mark, I think we do have to go out and actually interview people, understand what's happening, and I think you need to help us figure out how we can help you do that. Our first plank is consistent blood pressure recording. So one of the things we find is simply having the blood pressure measurements from all of the individual office visits and then just sort of lining them up. You can see that a physical phenomenon, which should have a nice smooth distribution, is actually being measured and recorded with a strong preference for multiples of 10. So here, this is, you see we have systolic blood pressure over here, diastolic blood pressure over here, and you can see that across most medical groups, and this is just a sampling of a few, and you can see sort of the general distribution of patients, but there are a lot of patients where the blood pressure is getting recorded as a multiple of 10. People are being approximate. For the manually taken blood pressures, there are really very few odd numbers at all. Most everything is even, which is probably close enough. But you can see, for example, that some of the medical groups are actually using automated blood pressure measuring devices. And so that, I think, is an interesting, that's the kind of distribution you would see. So I think that's another thing we can do is, this is, again, these are historical data, and I think one of the things that we can do is, as a group, sort of work on how you reduce those, improve the precision of the measurement of the, of blood pressure. So, and our first webinar for the measure up, pressure down thing was actually on the measurement of blood pressure. So one of the other things I thought we could do is briefly go through a little data and sort of look at what's happening in terms of which medications are being used. And so what I've got here, and this is pretty busy, but let's just focus over on the lower left. What we're looking at here is patients who are who have a visit in the past year, so a visit in 2012, a patient whose blood pressure going in was 100, so this is the last blood pressure in the year before, was 145 over 95. So they're 150 over 95. So they're a little bit out of control. And then we're just looking at the medications that they are on. And this is not to necessarily say that there's one right or wrong way of doing this, but just to sort of get a sense of kind of what the variation is. And it's to get you thinking about what kind of data we've got and what's available here and how we might use it. And then we'll talk more tomorrow about actually doing that. So if we look across all groups, and the way we typically do these things is you can see which groups over here have the larger numbers of patients or the smaller numbers of patients, because sometimes when we drill down we don't have very many patients in a particular category. So we're looking here at the number of the patients who are on 1, 2, or 3 medications, and we can add more if we want. I've taken the ACEs and ARBs and put them together because they're kind of, you can kind of think of them together. And I've taken all of the diuretics and put them together. I've got another version here that breaks out the thiazides, but it's even more bands. But it's kind of interesting just to see, and so I think part of the question is just if you have data like this, how might you use it, and how might we learn something from it, and how might we learn something from the variation that we see from group to group over here. So we're not talking about the outcome and how many of these patients wound up being controlled at their next visit. But you can see here, for example, that, and the way this is we have to actually read the ones and the zeros to figure out which combinations these are. But you look at this sort of light tan sort of color here. I guess the important thing is that there aren't very many patients at all on no drugs. So that's kind of a good thing. And then here's the proportion of patients that are on 1, 2, and 3 drugs. And of course, we have some patients who are on 4 drugs because we don't have a top end to the blood pressure here. But here, for example, is the ARBs, ACEs and ARBs are this big block here. And so that's 56% of the patients who are on 1 drug are on an ACE or an ARB. And the majority of these patients, small majority, or small plurality of these patients are on 1 drug. The next one is a diuretic, most thiazide diuretics, but some others as well. And then a calcium channel blocker is down here, and beta blockers, which we've been talking about beta blockers, and so you can see that they're 18% of the total of patients who are on one drug. And of course, they may be on beta blockers for other reasons. So we probably should do a little looking at comorbid conditions in order to do that. So here are the patients who are on two drugs. The red up there is an ARB and ACER and ARB and a diuretic. So the combination that is kind of the first line combination for Kaiser, for the Kaiser protocol, is actually a relatively smaller group overall for us. And so we go down to an ARB and a calcium channel blocker here. There are actually a few more of those. We have an ACER and ARB and a beta blocker combination, and a diuretic and a calcium channel blocker, a beta blocker and a diuretic. So I think one of the things that's, and of course you can see here what we're doing here is sort of aggregating that for all of the patients who are on 1, 2, or 3 drugs, and then being able to look across. And of course we can look at the outcomes as well, but I think that's the data resource we have, and it might be interesting to sort of get a small group of people together to do some kind of exploration of data like this. And we would be very eager to work with folks who would like to use this as a way of understanding sort of how much variation there is among our groups. You can see there are some people who are less likely to use beta blockers than others. Those kinds of things that are sort of consistent about it. So anyway, this is just what we have available. I don't know, any thoughts or comments? These are kind of complicated displays. They are not answers.
We have a lot of variation decrease.
We do have a lot of variation, don't we? Yeah. And of course there would be even more variation if we were to look at subsets of the patients and that sort of thing, because there's a lot of averaging going on when we put this together. Does anybody want to get a group together to look at this this sort of thing, and would be willing to engage with other groups around this? Yeah.
Sure, I think it's a great idea. It looks like Tableau, so I think
yeah. Yeah, this is Spotfire, but it's the equivalent sort of thing. Yeah, exactly.
It would be interesting to see if there's any correlation with this data and the control.
Yeah. Mm-hmm.
What combination of drugs or some other kind.
Right. And of course, doing a little control for other, because I think one of the things we can do is a bit of an observational sort of regression model on this thing, and but what would be helpful is to have a few folks who would help us sort of set that analysis up, and what factors we should be thinking about and that sort of thing, because we are not experts in hypertension, and nor in, I think again, it's not that there's one right combination of drugs. I think the message is how consistently are things used. So I think the question of variation, where Dick was going at the beginning, I think is exactly one of the things we want to learn from this, not the proportion of this drug or that drug that is associated with a particular outcome. But I just wanted to kind of present this as a, we have data like this. This is what we get when we take all of the Humedica data and put them together. And I think folks that are interested in helping us use this to try to understand how the variation or the choices that are made affect the outcome would be useful. Yeah.
Well, this is very similar to what, so I saw this graph before, and it looks very much like first of all, it looks very much like the graphs that we have also. And we had the same questions, that we have all this data, so what does it mean? And what we did, and I don't know if it's the right or the wrong thing, but we had two things. One, we plotted this against performance, and we said, oh, does one drug tend to correlate with performance? But when we did that, we interpreted that to be a surrogate for interest in activity. That just because one medical center prescribed a lot of the drug, we didn't really think it was the drug that mattered. We thought it might be a sign of an organized system, a medical center that had their act together. That's why we did a site visit. But we did use it, we did do some of these gaps to say something like, well, some medical centers have very few prescriptions for this drug. And we all agree based on the protocol that that's probably an important drug. So maybe there needs to be an educational campaign at that medical center about the importance of this drug. So we did a little bit of that. But the challenge is that sharing this without knowing where you want to go, I think you need to do two things. You need to figure out where you are, but also, suppose you say, we think any of these three combinations is really good because we believe it, or because we think it's more affordable, or it's more consistent, or we can execute it, or whatever it is. And then you can start to shape which medical centers are closer to what you think the ideal model is. That's what we did. And we're pretty linear. Look, you could argue that ACE-R plus calcium channel blocker is better than ACE diuretic, and I wouldn't argue if you said that. We just didn't choose that. So I don't know that that's wrong. And so you might bundle them. You might say, well, we think, based on Accomplish, ACE diuretic and ACE calcium blocker are equivalent. And so you might put those together, and then you might see something different when you look at it based on any of the top two. So it does take a small group with a little bit of understanding about dynamics and drugs to do it. And hopefully you'll come up with something. I mean, you have so much data here, I know you'll come up with something. We ended up using something like this to basically say, people on 3 drugs who are out of control, not on a diuretic, should be on a diuretic. I mean, that's what we did when we had all that. People said, okay, yeah, so then you get you out of what the first 2 or 3 drugs are, but because that's the definition of hypertension. And then we said, look, at your medical center, you have all these uncontrolled, and look how low your diuretic prescription is. So it's almost the inverse. It's almost what you're not on. And that's what we ended up doing. And I don't know if that's any better or something you can come up with, but yeah, I think it would find that nugget for something which is actionable, and then you can develop a campaign. Then, what we did, then we developed a campaign around it. But it looks, I tell you, I mean, if you didn't, I could put the names of all of our medical centers up there, and we could show this at one of our meetings, and people would just, because one of our graphs.
You mean the way you were or the way you are now?
The way we were. The way we were. But sometimes we change the colors. Sometimes, like the way you bundle the diuretics, we might bundle them. And what we do is we just do other. Basically, what we do is we want to know beta blocker, ACE-R, diuretic, calcium blocker, right? And I think we might have done alpha. I can't remember what we did alpha blocker. I think we just did the 4 drugs I mentioned, plus spironolactone, and then other. Because frankly, the other is distracting when we look at it. So I think if you decide, hey, here's our 4, 6 drugs, then you might do that. Then it just makes it more readable. But this is a working document, which is different from when you're going to flash up in your executive meeting.
One question I forgot to ask, if I could ask you. There's a lot of talk about refractory hypertension, resistant hypertension. There are a number of renal sympathetic denervation catheters that are in the pipeline for FDA approval. What's your take on that component of the problem and the solution?
Well, I don't have a lot of experience with, I'm going to the ASH meetings and next meeting here in San Francisco, but I think that probably still applies to a limited subset of our patients. And I think even though that's promising, I think right now we just need to double our efforts on identification of those unknown and using the affordable drugs, the affordable, safe, effective drugs that we already have. And so Kaiser, we're not always the first to embrace a new slick. We let others kind of teach. So we're kind of a little more conservative. So we're going to do what we believe is more traditional, conservative, proven, but we're open to suggestions. So we're going to be watching that, but we're not banking on that. We think we need to look to the past to continue to do what seems to have been working for us.
Independent of the therapy, have you stratified your patient population to sort of know what proportion would
Yes, so
qualify by the traditional definition?
Yes, so we do know, so we have these, we actually have, so we have this graph with, okay, what we've done is that we pick we just make it binary because we're not sure what JNC8 is going to say about whether there should be a different target or a new target, and he doesn't remember they dropped a different target for hypertension, and then they made the systolic thing for 80 for diabetes. So it's just so crazy, we just said, you know what, we're just going to do 140 over 90. And that's what we're just going to do for now, because we don't know what to do. So that's one way we simplify things. And then we just, so everything is, the key is simplify, simplify, simplify. We just simplify the threshold, and either over or under, and then we simplify the meds, we bundle them into just 5 categories that we think are done. And then when we share the groups, for example, we are moving towards patients on 3 drugs whose blood pressure is, say, stage 2 hypertension, 160 over 100. Because we think those people need a 3rd drug more than the stage 1 hypertension. So yeah, we do that, and we say, here's your list, and of those patients, how many of them have normal renal function who aren't on spironolactone? Again, but this is just it's twofold. It talks about what our population is, and then also something which would be actionable if you printed out the patient numbers. So there's 2 strategies. One is, hey, in general, we should be prescribing more of drug X, let's say spironolactone. In particular, here's 75 patients in your clinic who might or might not be, who it just looks like maybe they're candidates for spironolactone. Doesn't mean they need to be on it, and then the doctors go, no, you can't. But sometimes the doctors go, oh yeah, sure, for half of those patients. So we'll do some of that outreach too. So that's sort of stratification.
Okay, great. John?
It occurs to me when I look at my numbers, our numbers, and obviously these are not satisfying to look at. But when we looked at our primary care doctors and our cardiologists, we combined that, we seem to do much better. This is unlike what Dr. Jackie was saying. He said 90% of the blood reviews being done in primary care. But I wonder, is there something different about the practice that I'm in? Because when I look at the global, and that's the global, you've got everybody. It's everybody who's sitting on my practice, right? It's not isolated to primary. We seem to get very, very different numbers. It's dramatically different. I don't know what that means for us or for anyone else who's going to have that same issue.
Different in terms of control or different in terms
Yeah,
of
if we look at primary care and we get combined cardiology figuring they would have an interest in this, our numbers are much better. Now, obviously, so those numbers you're showing don't match up with our internal numbers that we get from the medical product. When we look at it, but again, we're pulling it down to primary care cardiology and saying, and we were thinking, yay, we're doing great, and then we come and see that, no, we're not doing that great. I mean, is everybody, that has made anything? What does that mean?
Well, we're
how am I going to address that issue?
Actually, we're going to talk a little bit tomorrow about what we're calling designated providers, which are the folks who are in primary care that you identify that you want in your dashboards and OnShare. Because that is actually, we have those for some groups, 7 groups out of the 21. We have designated providers, and there are differences. So I think that's part of the conversation tomorrow. And it could be that the specialist referral process is being selected for a particular subset of patient population that has more complex problems.
Yeah, maybe it means that I need a mechanism. We need a mechanism for getting people that are in the specialty and the surgical centers to the primaries. Maybe that's what we need to be focused on, so that the primaries can go do their work and improve our numbers. Because
we did that. So, but it was more because it was a belief. So we actually did the same thing. So the primary care saying, the urologists are killing us. I've got this blood pressure perfect, and now the guy gets talked about prostate cancer because PSA 3.1, and now his blood pressure is high, and you're killing my numbers. So when we did the data search, we realized it really wasn't killing our numbers. But someone had a high blood pressure in specialty care. We wanted them to help us measure it. And so we actually developed a process that very easily get them. But actually, turns out they come back and they get a blood pressure measured by that non-doctor thing where it's done in a controlled environment. Patients relaxed in a familiar setting. So we do that.
So you follow up on every elevated blood pressure. There's some mechanism you're going to follow. So if somebody's seeing in urology, their blood pressure's up, that person's going to see within some X period of time and get this addressed.
Yeah, we have and they say, because they don't know what to do, so we say, well, if it's this high, it's one day, if it's this high, it's a week, if it's this high, it's a month. Yeah, we've had all that, and we made it very easy. So it doesn't always work, but we did the same thing that you did. So it's in there, done. We did that, and it helps engage the specialists feel more comfortable checking the blood pressure when they know they can get it to someplace who can take care of it. So we found that actually helped primary care specialists. Yeah. Exactly.
All right, well, thank you very much. We really appreciate your input. This has been helpful. I'm sorry we don't have any, immediate insights from a whole bunch of complicated data, but that's what we're all here to figure out. And I think we've got a lot of guidance about how to approach our data to impact. Yes, Gordon?
You say how to measure controls based on those uncomplicated and complicated?
That's the blended rate, yeah.
Okay.
Yeah, that's the blended rate. And of course, that depends on how many you have, which is one of the things that varies across the groups. So anyway, lunch is next.
21st floor.
21st floor, so up in the elevator.
And if anyone hasn't voted yet, you can vote at your table for the topics for open space. We'll tally those up. And then we'll meet back down here at 12:45 for the inspection.